So, welcome to the nerve physiology session. Since you all know that we have completed the entire muscle physiology, we have already discussed how a neuromuscular junction acts. In that, I have left with one small clinical topic which I will be covering. Then we will move on towards the nerve physiology. In muscle physiology per se, if you take, I told you that there is a muscle. In that muscle, you have a nerve fiber which is present as a fascicle. These nerve fibers, every time when there is a force of contraction, there is going to be a tension. Every single cell is going to have a risk of rupture due to this tension while the muscle contracts. That means your muscle has to rupture. Is it rupturing every time? No. That means there is some defense mechanism that are present in your skeletal muscles that prevents this rupture. What are they? They are nothing pure. I think you would have read at the first beginning of muscle physiology. I told you structural proteins. In that, dystrophin, dystroglycan, laminin. I think these three important collagens I have told you. Dystrophin, dystroglycan, and laminin is nothing but collagen. These three materials, they dissipate the tension outside to the extracellular matrix, by which the tension is dissipated, and it makes sure that the tension is not propagated inside your muscle and lead to rupture of your muscle. Is it clear, guys? When there is going to be some problem to this dystrophin, when there is some problem to this dystrophin, dystroglycan, and your laminin, this leads to some syndromes or dystrophies. What are they? Number one, Duchenne muscular dystrophy. Muscular dystrophy. Number two, Becker's muscular dystrophy. What are these two? This is what we are going to see now before we move towards the nerve physiology. Duchenne muscular dystrophy is nothing but when there is a complete absence of dystrophin gene. This dystrophin gene itself is absent. When it is absent, when this dystrophin gene itself absent, due to some genetic mutation, it leads to Duchenne muscular dystrophy. What happens in this? There is absence of dystrophin protein. Because of it, you will have following symptom. Number one, pseudo hypertrophy of calf muscle. Number two, Gover's sign. I think all these things you will discuss again in pediatrics. We will discuss that while we are talking about pediatrics. But now remember, pseudo hypertrophy of calf muscles and Gover's sign are the two important things which will be present in the Duchenne muscular dystrophy. Then you have this Becker muscular dystrophy. What happens in Becker's muscular dystrophy? Here also same dystrophin gene is mutated, but it is not completely absent, but there is a dysfunction. So instead of absenting itself, there is a dysfunction of dystrophin gene, So when there is a dysfunction of dystrophin gene, you call it as Becker's muscular dystrophy. Here what happens? There will be less severe symptoms. But how to differentiate between the Duchenne's muscular dystrophy versus Becker's muscular dystrophy by a simple test, that is muscle biopsy. When you take a muscle biopsy or for dystrophin, what happens? In Duchenne muscular dystrophy, it is complete absence. So you will have negative. Whereas in Becker's muscular dystrophy, you will have positive. But here there is a dysfunction of your dystrophin protein. This is one important applied physiology which I have left with. Now moving on towards the nerve physiology. Okay. Talking about the nerve physiology, I think you all have already discussed in the general physiology about how action potential is generated, how a nerve is going to be present. This neuron, about this nerve physiology, this is very important because not just in this chapter, but when you're going to talk in the neurophysiology, when I start with the neurophysiology, I will again discuss all these things, or sometime what I will do is I will skip that part. So I want you guys to be ensured that you understand the concept then and there before we move further for the physiology. Is it clear? Now, starting with the nerve physiology, you have a nerve cell, you have a neuron, nerve fiber, you have different names, but ultimately everything is same. What it is? Nerve cell, I call it as neuron, I call it as nerve fiber, whatever it is, everything is nothing but the same. Okay, I want you all to understand that first. Okay, now starting with, there are two types of nerve basically, or a neuron. Okay, nerve cells. Nerve cells are basically of two types. One is your neuron, other is a glial cell. Okay, so there will be a team will be consisting of two type of people, isn't it? One will be doing the work, other will not do the work, but will be helping the person who do the work, and they coordinatedly complete it. Okay, there is two options. Either you can involve directly, or you can encourage the person or support the person who is doing the work. Similarly, your nerves are of two types. Neuron, the cell which do all the processes. Whereas there is second type called as glia, which will be a supporting to the nerves. These are the two types which you need to understand. Okay, a neuron, a nerve cell, a structural and functional unit of a nervous system. All underlined words are very important. It is an aggregation of neuronal cell body that is located inside the new CNS. You call it as nucleus. When the same thing is located outside the CNS, the aggregate of neuronal cell body is called as ganglion. Okay, the neuron as nerve cell body, that is called as soma, and you have two type of processes. It's like a branches of tree, dendrites and the axon. Okay, nerve cell means neuron, nerve cell body means that soma. If you can see in this picture, the central thing is called as nucleolus. Then you have a cell body, that is your soma. From there you have the branches like Christmas tree, isn't it? That is called as dendrites. Then you have a tail-like structure that is called as axons. Actually, an axon is just like this. Okay, from your soma, just like a tail it must be. But you can see there is something that is surrounding it. Can you see? There is something that is surrounding it, and that is called as myelin sheath. That is called as myelin sheath. Okay, that is called as myelin sheath. I want you all to remember that. Next, these myelin sheath, okay, that is present inside your central nervous system, is called as oligodendrocyte. I want you to remember carefully. So you have a glial cells. Remember, you have a glial cells. I told you. Okay, sorry, I will recorrect my sentence. You have a myelin sheath that is insulating. This myelin will have supporting body attached to it. Now the sentence makes clear, right? The myelin sheath is present. Above the myelin sheath, there are some protecting structures or surrounding structures that make the myelin. Okay, so something has to make the myelin. That making supporting structure is what I call it as a supporting cells or glial cells. This glial cells, inside the central nervous system, your neurons are covered by a specific structure that is called as oligodendrocyte. And outside the CNS, you will have one more different structure that is called as Schwann cells. So, oligodendrocytes, Schwann cells are some of the examples of glial cells. Now you know what is oligodendrocyte. Now you know what is Schwann cell. Okay, apart from it, you will have some other glial cells. One is astrocyte. I'll tell you in detail about all these things later when you're going to discuss or start with the central nervous system. Now you have to remember just that this myelin is going to be made up of some of the glial cells. What are these glial cells? These glial cells are supporting structure. They do not involve in the electrical signaling. They are not excitable. They are just a protecting structures. Okay. Then you have the axon terminals. These terminals are the place where there is going to be neurotransmission. That is what called as terminal cleft. Clear, isn't it? Okay. Now, moving further, now you have to understand what is the neuron. So, all neuron contain one axon, but many dendrites will be present. Axons carries information from cell body away, but dendrites carries towards the cell body. That means it is going in this direction. This is going to be your cell body. You're going to have dendrites. It's going to be axon. Okay. It's like any other cell body, but with some specialities. You're going to have a cell membrane. I don't want you to describe this, very important at all. This is going to be a 12th standard topic. You know how a neuron is going to be there. I have also mentioned everything. I'll tell important points alone. You read up all this in the PDF which I am sending you. The membrane is going to be containing receptors, ion channels, pumps, etc. Chromatin material is completely more active and there is a continuous transcription that is going to be occurring. The structure of neuron, this is how it is going to be there. You're going to have all those ribosomes, Golgi apparatus, mitochondria, everything will be there. Apart from it, you will be having a calcium. Yes, isn't it? You need calcium for the concentration. That is how it is going to be stored inside the sarcoplasmic reticulum. Then you have this Nissl granule, very important content. They are found in the motor neuron. They are found in all parts except in your illock, axon illock, and axon disappear when the axon is severed. Okay, Nissl's granules are involved in the protein synthesis and they contain iron. These proteins are needed for maintaining and repairing production of neurotransmitter and the enzyme. Then you have to know what is chromatolysis. I think this is very important. The disappearance of this Nissl granule following some injury, you call it as a chromatolysis. I need you to understand this because this is one of the steps in the degeneration of your neurons. So this is going to reappear when the neuron recovers. That means that your prognosis can be accessed by chromatin material. Okay, that is your Nissl's granule. And there are some other inclusion materials, inclusion bodies in the neuron that are going to have some pigmenting, secretory, and other activities. Now coming to the axon, you know this is how the axon is going to be there. Axoplasm is going to be ensheathed by the membrane called as axolemma, or how your neurolemma, okay, sarcolemma, everything is going to act. Same way this is going to be there. Remember, your axons is there, right? That axons or axoplasm doesn't have Nissl's granule. That is what I need you to understand in this slide. Next, okay, so this is going to be the axons. These axons are going to be added on by the myelin sheath. This myelin sheath is again surrounded by the neurolemma. This neurolemma contains Schwann cells. That is how it is going to be there. In a peripheral nervous system, it's going to be Schwann cells. In a central nervous system, it's going to be oligodendrocyte. Now coming on, why do you need a myelination? So myelin is going to insulate your nerve fiber and fasten the conduction of impulses. Okay, it's going to fasten the conduction of impulses. Your myelin is going to be speeding up the impulse conduction by permitting action potential to jump from one naked region of axon to other naked region of axon. That we call it as saltatory conduction. So what we call it as? We call it as a saltatory conduction. So we call it as saltatory conduction. This myelination begins at 4th month of the intrauterine life and it is going to be completing few years after the birth. Example, pyramidal tract remains unmyelinated at birth and gets completely myelinated at the 2nd year of life. In sensory now, myelination occurs even in fetal life. In motor now, it takes 2 years to complete. This myelin sheath is going to be surrounded by lipids like your phosphatidylserine, serine, cholesterol, cerebroside, sphingomyelin, etc. And outer aspect, it is going to be covered by some proteins. So it's going to be Schwann cells or oligodendrocyte cells, etc. Outermost cell membrane of Schwann cells is neurolemma. Schwann cells lays down myelin in the peripheral nervous system. ஒருவேளை உங்களுக்கு mylination நடக்கல, Abdena, the diameter of nerve is very small, therefore there will be no nodes of Ranvier. In central nervous system, neurolemma is not there. It is going to be through neuroglial cell called as oligodendroglia or oligodendrocyte. Neurolemma is essential for regeneration of injured nerve, which is it is absent in the CNS optic nerve, and regeneration does not occur. Remember, you need neurolemma. Neurolemma is present only in the peripheral nervous system. Now you can understand why there is no regeneration when there is going to be a CNS nerve injury, optic nerve injury. Okay, each nerve fiber is surrounded by a thin but a tough fibroelastic covering that is called as endoneurium that is going to be separating you from the adjacent structures. Several fibers are bound together from bound bundles. Fasciculi, it is covered by perineurium. Again, there is lots of fascicles that are going to be bundled together to form epineurium. Okay, that is what the same way we are just like onion. We are going to break down and see the nerve. Myelination is very important, as I told you, when there is going to be a demyelination. This is what I want you to remember. Okay, you have a myelin basic protein, myelin oligodendrocyte glycoprotein. All these proteins, okay, they are going to be affected. When there is going to be a affection, your myelin will be damaged. When there is a damage to the myelin, that will lead to several diseases. When there is a disease of oligodendrocyte, you call it as multiple sclerosis, demyelinating disorder. Similarly, you have proteolipids. Okay, they similarly are going to have proteolipids. When there is a problem to this proteolipids, mutation to this proteolipid, it leads to Pelizaeus Merzbacher's disease. Remember? So this is going to be due to mutation of proteolipid, mutation of proteolipid protein, mutation of proteolipid protein. Remember? So then comes the peripheral. Okay, when there is a peripheral myelin protein. So similarly, you have various proteins in the peripheral nervous system also. One of it's your Schwann cells, I accept. But apart from Schwann cells, you also have P0 protein, peripheral myelin protein 22, okay, PMP 22, as well as your myelin ganglioside, myelin associated glycoprotein. So here what I want you to remember is, okay, in CNS, I'll just tell you 1 minute. So what happens, just remember, in central nervous system. So in your CNS, in PNS, in both, you have 3 categories. Okay, in central nervous system, you are going to have myelin basic protein, you have myelin oligodendrocyte glycoprotein, you have proteolipid, So when there is damage to this two, it leads to multiple sclerosis. When there is going to be a mutation to proteolipid, it leads to Pelizaeus Merzbacher disease. Okay, so 2 things we have seen. And in peripheral nervous system, you are going to have P0 protein. This P0 protein lower mutation erpatta, that leads to Charcot-Marie tooth disease. What is this? Is it a tooth disease? No, it is a sensory neuropathy. It's a sensory neuropathy. This has different types. In that, type 1B. Type 1B is caused due to this P0 protein mutation. Similarly, you have peripheral. Similarly, you are going to have peripheral myelin protein. Peripheral myelin protein 22. That is going to be PMP22. The PMP22 mutation will lead to same Charcot-Marie tooth disease, but it is going to be type 1A. Type 1A. Clear? Apart from it, you have hereditary liability to pressure palsy. That is, so autos. What is that? Hereditary liability to pressure. This is one another disease. You call it as HLPP. HLPP disease. It is autosomal dominant disorder characterized by pressure-related mononeuropathy. Now, coming back to, there is a both in central nervous system as well as in peripheral nervous system. You will have certain diseases. Okay, certain proteins, myelin proteins. What are they? Number 1, myelin ganglioside. Myelin ganglioside. This myelin ganglioside mutation, GQ1B, this leads to one important disease called as Guillain-Barré syndrome. Okay, Fisher variant of Guillain-Barré syndrome, which is characterized by demyelination, ataxia, ophthalmoplegia, areflexia, and anti-Q1B, GQ1B antibodies will be present. That is myelin ganglioside when there is any mutation. Similarly, when there is myelin-associated glycoprotein, myelin-associated glycoprotein mutation, that is going to again lead to peripheral neuropathy. Peripheral neuropathies. Okay, so clear. I want you to remember this para alone. I want you to remember this paragraph alone. Okay, now coming back to the point which we are discussing. So each function, okay, now are you clear about this myelin protein? Myelin is formed by oligodendrocyte in central nervous system. Myelin is formed by Schwann cells in peripheral nervous system. Oligodendrocytes can myelinate multiple neurons at a time, whereas Schwann cells can myelinate only single neuron. I'll show you this also. Okay, nothing. Just remember like this. I'll show you. Just remember like this. What happens? Your myelins in a normal, okay, just so just remember. So in a normal cell, it's going to be like this. Okay, it's going to be something like this. You're going to have axons like this. In the axons, you're going to have a myelin sheath covering like this. Okay, so this is going to be present. In a peripheral nervous system, you're going to have a single connections. In peripheral nervous system, Schwann cells are present. This peripheral nervous system is going to be having a single myelination, single nerve myelination, where all it will be present. So your peripheral nervous system is going to include number one, cranial nerves 3 to 12. 3 to 12 cranial nerve. Second thing, it is going to include spinal nerves. It is going to include spinal nerves. And number 3, it is going to include the Schwann cells. Okay, that is going to be your Schwann cells. So all these things, spinal nerves, cranial nerve 3 to 12, all these things have a regeneration capacity. It has regeneration capacity. That is what I need you all to remember. It is going to have a regeneration capacity. Therefore, if injury, it has a good prognosis. If injury, there has a good prognosis. That is why when you're going to have a fracture of your hand, when there is a damage to nerve of your hand, after a physiotherapy, after multiple interventions, you will be able to recover. Whereas you will never be able to recover when there is a head injury, when there is an injury to the brain. Why? Because when there is an injury to the brain, okay, remember, because when there is an injury to the brain, there is going to be damage of your central nervous system. So since it is not a Schwann cells, it cannot be able to regenerate. Since it cannot be able to regenerate, you cannot force for any regeneration. Recovery will not be there. That is what main point I would like to tell you is there won't be any recovery. You cannot expect recovery in which condition? You cannot expect recovery in case of a central nervous system injury. Okay, clear? Now moving on towards the central nervous system. Your CNS is going to be including number 1, brain. Number 2, all your central nervous system, all your spinal cord. Okay, entire spinal cord. Number 3, central cranial nerves 1 and 2. Okay, all these things are covered by, this is going to be covered by Schwann cells. This is going to be covered by oligodendrocyte. Oligodendrocyte. What is the specialty in oligodendrocyte is, when there is a neuron like this, you have another neuron like this, you have another neuron like this. What happens is, everyone are going to be interconnected. How it is going to be interconnected? All of them are going to get interconnected by one thing called as your oligodendrocyte. Where will this oligodendrocyte be? Your oligodendrocyte are going to be at the center. First one, you're going to have myelin sheath like this. Okay, then you're going to have myelin sheath. Just consider. So just consider you're going to have myelin sheath like this. Then you're going to have myelin sheath like this. 3 myelin sheath, I'm just going to tell you. Fourth also, I think if I draw small, I can just get you small also. 1, 2, 3, 4. Similarly, I'm drawing here also 1, 2, 3, 4. Okay, so first consider these two neurons. These two neurons are going to be interconnected. These two neurons are going to be interconnected. How? They are going to be interconnected like this. 1, 2, 3, 4. 1, okay, so this is going to be again interconnected. Going to be like this. It is going to be interconnected like this. Similarly, you are going to have interconnection between this. Okay, so you're going to have between this interconnection. So this is going to be one oligodendrocyte. This is going to be the other oligodendrocyte. What happens because of it is, okay, because of this interconnection, there is going to be a, what happens? There is going to be a large amount of transmission. Okay, now you remember, you just see in our cortex, there's a sudden rapid transmission of impulses, isn't it? Impulse is going to be transmitted faster. This fast transmission is given by this oligodendrocyte, which interconnects between one neuron and other neuron. So there is a large interconnection between one neuron and the other neuron. That is what we call it as that is what specialty of our central nervous system. Now, from the functional point of view, you divide the neurons into 4 categories. I think these all just you would remember, not so either. So one is your receptor zone, site of origin of conduction of impulse, zone of all or non transmission, zone of secretion of transmitters. So then axoplasmic transport is there, sudden transport is there, retrograde, anterograde transport. I think all these things you can read by your own. Then structure of neuron, dendrites, axons, all these things you need to understand. Now coming to the genesis of action potential. How is the action potential just stimulated? Think all these things we know ourselves, but again, I need you all to brush up. So what is action potential? It is the primary electrical response of a neuron. They are going to be forming the main communication. So what happens is you have an axon. Okay, you have a cell body. You're going to have like this. There is going to be dendrites. There is going to be dendrites like this. Okay, so then there is going to be dendrites like this. Okay, there is going to be the various dendrites. These dendrites are again going to be forming a large like this. It's going to be like a tree. Okay, it's going to be like a tree and okay, so this is going to be a dendrite. So this is going central, you are going to have soma, that is going to be a cell body. What happens is actual synaptic region is going to be your ligand gated sodium channel that is present inside your that is going to be present at the end of your this is going to be again your myelin sheath. I'm just drawing quickly. So it's going to be myelin sheath and you are going to have a dendrite. So this is how our neurons will be. So this is going to be a synaptic terminal. Now, how your impulses are going to be present? I'll tell you. This is very, very important point you need to understand, because first in cell body, this cell body is going to be present between one neuron to another neuron. How transmission occurs is between the this point. This is your synaptic terminal, isn't it? From this axonic terminal, dendrite is going to get the impulse. And your nerve is also going to have very important thing, that is they can be able to transmit the impulse. They can be able to produce the impulse. So normally resting membrane potential is going to be minus 70 millivolt in neuron. In response to some stimuli, what happens? First, there is going to be a opening of voltage gated sodium channel. So there is going to be opening of voltage gated sodium channel. Now what happens? Your sodium is going to enter into the neuron. Since the amount of sodium that is entering is very, very small, it can only bring about changes up to 15 millivolt. So this voltage gated sodium channel brings about 15 millivolts of current. Okay. Now existing resting membrane potential is going to be around 90 millivolt, minus 90 millivolt. You are just bringing minus 70, right? In a nerve, it's going to be minus 70 millivolt. If you are going to just bring minus 15 millivolt, which will be amounting for minus 55 millivolt. Okay, at this minus 55 millivolt, what happens is, so this is going to be called as a threshold level or firing level. So now the minus 55 millivolt entry of sodium causes opening of more voltage gated sodium channel. This leads to opening of more voltage gated sodium channels are going to be opened. Okay, channels are going to be opened, and this is going to cause depolarization. This is going to cause depolarization. Remember, so this positive feedback is called as Hodgkin's cycle. Okay, this is called as Hodgkin's cycle. You have to remember. So because of this reason, minus 55 millivolt is called as firing or threshold. Now what happens at this minus 55? There is a rapid upstroke of membrane potential. The membrane potential move towards the equilibrium potential, that is plus 60 millivolt. Okay, அது வரைக்கும் போகும். Okay, so அது வரைக்கும் போகும்போது என்ன ஆகும்னா numerous sodium influx is going to occur through 50 to 75 voltage gated sodium channels that are present, and through the nodes of Ranvier, that is 2000 to 12,000 nodes of Ranvier are available. Then what happens? There is going to be a potassium efflux. This is going to be followed by potassium efflux through voltage gated potassium channel, through voltage gated potassium channels. Because of this, what happens? There is going to be a repolarization. And when it enters at the end, what happens is more potassium efflux are going to occur. This leads to hyperpolarization. At this level, there is going to be inhibitory substance called as GABA. This GABA is going to come and inhibitory neurotransmitter produces all its effect by inducing hyperpolarization. So in the stage, the hyperpolarization அப்புறம் அதுவே அப்படியே ரெடியூஸ் ஆயிடும். இது ப்ரொடக்ஷன். இப்போ அதுக்கப்புறம் என்ன ஆகும்னா அது டிரான்ஸ்மிட் ஆகணும்ல இம்பல்ஸ். ஓகேவா, இம்பல்ஸ் டிரான்ஸ்மிட் ஆகணும்ல. இந்த பார்ட்டுக்கு பேர் என்ன? Someone can you tell me what is this part called as? Initial segment of axon. This is where the ATA, your action potential, is generated. அதுக்கப்புறம் என்ன ஆகும்? இந்த இடம் வந்து unmyelinated, isn't it? This is unmyelinated. At this unmyelinated, there is going to be around 750 to 1500 per micrometer square. Okay, so if action potential எப்படி போகும்னா ஒரு micrometer square 50 to 750 to 1500 போகணும். ஓகே, அது ஆக்சான் இல்லாக்ஸ்க்கு வர்றப்ப, இந்த ஆக்சான் இல்லாக்ஸ் வர்றப்ப, அதாவது செல் பாடி, இந்த இடத்துல செல் பாடி இருக்குல்ல, இந்த செல் பாடியில ப்ரொடியூஸ் ஆகிறது 50 to 100 தான். அது அப்படியே உங்களுக்கு அன்மைலினேட்டட் ஏரியா போக 750 to 1500. Then when it goes into this myelin sheath, it is going to be converted to 1500 to 2500 micrometer square. This place where it will be there at this much, at this point, myelin is increasing, and what is this point is called as node of Ranvier. At this node of Ranvier, what happens? There is going to be a rapid upstroke of your potential. So when it is, okay, now two questions are there. Where is the action potential created? At the initial segment of axon. Where is the action potential created? Initial segment of axon is the site of action potential, but that is going to be very short. Okay, then what happens? It is going to be going to the node of Ranvier. The node of Ranvier is the maximum action potential that can be generated in a nerve fiber. So three things you have to understand. Number one, in a motor fiber I am talking about. In a motor nerve fiber, number one, where is the initial site of action production? Initial site of action potential is going to be at the level of initial segment of axon. Initial segment of axon. Then where is going to be the maximum site of action potential? Maximum site of action potential is going to be there at the level of node of Ranvier. At the level of node of Ranvier. These two are very important. Okay, so these two are important. Now you understood, right? So once these two are important, next what you're going to do is in the, this is motor. When it is going to be in the sensory, what happens? Okay, in sensory neuron, what happens is even the initial segment of neuron is axon is going to be very short. Therefore, action potential is not created or it's not generated at the axon. Okay, it is not generated at the initial segment of axon. Therefore, action potential is created at the site of first node of Ranvier. At first node of Ranvier, that is what you need to remember. Now, once it is created, it has to transmit, right? How does this transmission occurs between one segment to other segment? How does this transmission occurs between one segment to other segment? I'll just carefully listen. You're going to have a neuron like this. Okay, I'm going to have this. This is going, let's consider this is going to be myelination when you're going to zoom inside. When you're going to have a myelination like this, what keeps the action potential multiplied rather than decreasing? Because it has to travel a lot, there has to be wastage of action potential, but the speed is increasing. The speed of transmission is increased by your myelin. Now, listen, this is going to be your entire cell. Now, what happens? Because of the sodium influx, what happens? There is going to be a action potential that is going to be coming. Okay, at the between your node of Ranvier. Always remember why when there is unmyelinated, there is going to be leakage of your action potential, reduction in the action potential, because there are lots of leaky potassium channels. There is lots of leaky potassium channels that are present. Because of the leaky potassium channel, what happens is there is going to be, because of the leaky potassium channel, there is going to be reduction in the action potential. But the myelin, what it does is, it not only it is going to prevent the action potential, but also there is some calcium which is going to be present at the beginning, calcium channels which are present in the starting point of your myelination. This is going to be promoting the exocytosis of neurotransmitter. Therefore, at this point of time, because see here you're going to have upstroke, but because of this node of Ranvier, there can be a reduction in the action potential. Even though there is a reduction in the action potential, once again, there is going to be a calcium channel opening. And when there are multiple sodium ion reaches reaches here, it's going to reach your NOR, node of Ranvier. When it is going to reach your node of Ranvier, what happens? It prevents the sodium influx, and also it is going to prevent sodium. It's going to be prevented because outside there are lots of sodium, inside there is going to be lots of potassium. This potassium tries to go out, isn't it? This potassium which is going to trying to go out. Okay, so when the sodium is coming outside, there is going to be more sodium, activation of sodium potassium channels. Therefore, your potassium, instead of influx, they are going to cause efflux. Okay, so because of instead of efflux, it is going to cause influx of potassium, and there is going to be opening of calcium channels. Because of all these things, there is again production of, there is a action potential. Because of this, there will be continuous production of action potential. Now it is produced here. Again, what happens? Now it is going to reduce at this point of time. Then because of the influx of your sodium, influx of potassium and calcium, again there is going to be action potential. Because of it, there will be continuous action potential which is going to be generated. At every node of Ranvier, there is action potential that is generated. That is why there is going to be a proper transmission of impulses. Now tell me, I'll give you a few conditions before I move towards the factors that are going to increase or decrease the conduction. I'll give you few important concepts. Okay, I'll give you few important concepts. Listen, bear with me, listen along with me carefully. Okay, now remember, I'll give you certain conditions. Number one, when there is a hyponatremia. Okay, let's imagine, let's consider there is a hyponatremia. Let's consider there is going to be hyponatremia. What happens in a hyponatremia? Okay, hyponatremia ECF hyponatremia, in ECF you will be having decreased sodium. There will be decreased sodium in the ECF. Whenever there is going to be decreased in the ECF, okay, sodium in the ECF, will it have any effect in the resting membrane potential? No. In resting membrane potential, there is not going to be any changes. Okay, mainly what happens is, it is going to decrease the action potential, because Thus, it decreases the size of action potential because sodium ions, which are responsible for the upstroke phase of action potential, is going to be affected. So upstroke is going to be affected. Because of affecting the upstroke, what happens? There is going to be decrease in the action potential. Similarly, now can someone tell what happens in hyperkalemia? Hyperkalemia, what happens when there is more extracellular potassium ion? It hampers the diffusion of potassium from inside to outside. It's going to hamper the transmission from inside to outside. Okay. When there is going to be increase in the potassium in ECF, it hampers the conduction of impulses. Because of this, what happens is positive charged ion will be moving into the more amount of positive ions will be present inside the cell, and it will lead to more excitability, more action potential. Then what happens in hypokalemia? In hypokalemia, the neurons will be first in the problem. Sodium is nice, so there is going to be a depolarization, followed by repolarization will also be there. But what happens is it is going to cause hyperpolarization. Since more potassium ion is leaving the cell, the membrane potential is further reduced. It causes hyperpolarization. There will be a hyperpolarization. All these things points are very important. Next, you are going to have hypocalcemia. What happens in hypocalcemia? Calcium ions are membrane stabilizers. A decrease in the extracellular calcium concentration, okay, increases the excitability of nerves by decreasing the amount of depolarization. Therefore, hypocalcemia இருந்தால் என்ன ஆகும்? There will be hyperexcitability. That means that there will be more amount of action potential. Similarly, in case of hypercalcemia, so an increase in the extracellular calcium concentration stabilizes your membrane. Therefore, what happens? It decreases the excitability. Unlike your skeletal muscles, don't confuse with skeletal muscle. In skeletal muscle, contraction increases in hyperkalemia, contraction decreases in hypocalcemia. But when you're going to consider about nerves, hypocalcemia will lead to hyperexcitability. Hyperkalemia will lead to decrease in the action potential. Why? Because when there is a decrease in the extracellular calcium concentration, it increases the excitability of the nerve by decreasing the amount of depolarization, okay, necessary to produce action potential. So the amount of depolarization necessary to create action potential is reduced when there is a decrease in the extracellular calcium ions. Clear? So this is what I need everyone to understand. Once you understand this, I think you all know about the action potential already in the previous session, in the previous general physiology discussion itself. So now straight away I'm moving towards what are the factors that are going to increase the conduction and what are the factors that are going to decrease the conduction. Remember, the conductions are increased by, as you all know, myelination. Okay, conduction is going to be increased by myelination, number one, whereas decreasing conduction is going to be unmyelination. Number two, the diameter of axon. So when there is going to be increase in the diameter of axon, that is going to cause increase in the conduction. When there is decrease in the diameter of axon, that is going to cause decrease in conduction. Similarly, when there is going to be thin axoplasm, that will be increasing the conduction, whereas thick axoplasm, okay, why? Because axoplasm will be causing resistance, okay, so that resistance is avoided. Then increase in temperature causes increase in the conduction, decrease in temperature causes decrease in the conduction. So that's all. This is the factors that are affecting the conduction, okay. Axon diameter, myelination, temperature, and you have to understand all these things. Next, I'm moving towards one important concept, that is going to be the classification of nerve fiber. Now moving on towards the classification of nerve fibers. When I'm going to consider classification of nerve fibers, there are different classification actually present. Okay, in that, one important classification which we will always take into consideration is the, anyone guess? Erlanger-Gasser classification. This is what we actually take always. Erlanger-Gasser classified the entire nerve fibers into A alpha, A beta, A gamma, A delta, B and C. This is how he classified. Okay, A delta, A gamma, A beta, A alpha, then we have B and C. Remember, in this, all your A alpha, from your A alpha to your B, okay, from your A alpha to your B, everything are going to be myelinated. They are going to be myelinated except your C, which is going to be unmyelinated. This is the first thing I want you all to remember. Okay, once you know that, then you have to know what are the motor and sensory autonomic relationship. Remember, your motor nerves, when you're going to consider, it is always going to be A. Among A, except your A delta, all other A is going to be doing a motor function like this, all these three are going to do motor fibers. Among them again, some can be extrafusal muscle fibers, some can be intrafusal muscle fiber. Do you remember? We spoke about the muscle bag fibers. Okay, fibers, muscle bag fibers, muscle chain fibers, all these things we read. So in all those conditions, they are going to be from the fascicle, inside the fascicle, from your nerve fiber. So which one are going to be from the nerve fiber, that we call it as intrafusal fibers. You remember that E gamma is used as an intrafusal fibers. So along with me, right inside this, it is going to be intrafusal muscle fibers. Intrafusal fibers. All these A gamma is going to be going inside your fascicle, intrafusal fibers. Remaining A alpha, A beta is going to be, both of them are going to be extrafusal. Extrafusal. Okay, it's going to be extrafusal fibers. One is over. Remember, these two, three are not going to be having any role in the motor function. Now coming to autonomic function. Remember, myelinated nerve fiber doesn't have autonomic function. Okay, except your B. B is also a myelinated nerve fiber. Therefore, it is also having a muscle function. It's also going to have a autonomic function. But which autonomic function does they have? The B fibers are going to be preganglionic. Preganglionic preganglionic autonomic system, whereas your C is going to be postganglionic. C is going to be postganglionic fibers. C is going to be postganglionic fibers. Remember, this C postganglionic fibers also have some other important thing. Okay, that is going to be a sympathetic and dorsal root. We divide C into sympathetic and dorsal root. Okay, dorsal root. This dorsal root actually has some important function, sensory function, apart from your sympathetic action. That is going to be, they are involved in pain and temperature. They are also going to be involved in pain and temperature. Now coming back to the sensory system. I think you all have to put one more box, that is sensory system. So what is going to be A alpha role? A alpha, I told you, they are going to be again going to be involved in the somatomotor activities, especially proprioception. Okay, touch and proprioception. Similarly, A beta is going to have a role in the touch as well as pressure. It is going to have involvement in the static proprioception. This is going to be dynamic proprioception, whereas this is going to be static proprioception. Okay, it's going to be static at the rest. Okay, who is going to be involved? Similarly, A gamma, they also have some sensory fibers. No sensory fibers, only motor fibers. They are going to be going as a motor to muscle spindle. They are going to be having a motor fiber to muscle spindle. Similarly, you are going to have A delta. A delta is going to be carrying superficial pain, that is fast pain and a cold. Whereas your C is going to be carrying again pain, right? That is going to be dull pain or visceral pain. This is going to carry visceral pain. whereas D is going to carry superficial pain. Superficial pain is going to be carried. Okay, with this, and cold temperature is also going to be carried, whereas here it's going to be carrying warmth, whereas here it's going to be carrying cold. Okay, very important. Similarly, now you need to understand which muscle is, which nerve fibers are named numerically. So we have other classification, that is numeric classification. So remember, numeric classification, it is going to be 1A. So A alpha is going to be 1A. Again, A beta can also be, A beta is going to be 1B. A beta is going to be 1B as well as 2. 1B as well as 2. A gamma is not considered. Again, A delta is considered as 3, and then B is not considered. C is considered as 4. This is what classification coined by numeric classification. Who coined it? It is coined by Lloyd. It is coined by Lloyd classification. Lloyd classification. Numeric classification is Lloyd classification. Now what I want you to remember is, you need to remember which is susceptible. Okay, so now 3 conditions I will take. Okay, before that I want to consider the susceptibility. That's why I'm talking. So considering the susceptibility, okay, you have hypoxia. Okay, number 1, there can be pressure. Injury can occur by these things only. And local anesthetic. Okay, this is what you have. I am going to divide. Okay, which is going to be more susceptible. Okay, more susceptible, intermediate susceptible, least susceptible. Okay, so always remember, for hypoxia, it is going to be BAC. Okay, B is more susceptible than A than C. For pressure, it is going to be A, B, C. For pressure, it is going to be A is going to be more susceptible than B than C. This is how you'll be classifying. And local anesthetic, for local anesthetic, it is again going to be A, B, and C. Okay, for local anesthetic, it is again going to be A, B, and C. I think you all understand. Okay, for local anesthetic, this is what important. Among them itself, you have some difference between your Ganong and your anesthesia textbook. Ganong says that local anesthesia, C is more susceptible, whereas anesthesia textbook says A gamma and yes. So whenever there is going to be a degeneration, so degeneration literally means than the nerves, we talk about the myelin sheath. So your central nervous system, you all know that oligodendrocytes are going to be present. So that is going to be developing antibody against it. There's going to be demyelination. So that is autoantibody mediated. Whereas we have certain nerve injuries, that is Wallerian degeneration. We call that degeneration as Wallerian degeneration. So before moving into that, you need to know what is the nerve injury. Nerve injury is common by having some trauma or by fracture, anything. We have 2 systems of classification basically. One is Seddon's classification, other is Sunderland's classification. Seddon classified as neuropraxia, axonotmesis, then neurotmesis. Only 3 things. Whereas Sunderland classified it as 1st degree, 2nd degree, 3rd degree, 4th degree, and 5th degree. 5 degree are classified. Okay, what happens? I'll tell you. 1st degree, your nerve is going to be in continuity. Can you see here? Your nerve is going to be in continuity only due to some local compression. Due to some compression or ischemia, only the local conduction is going to be blocked. Okay, but what happens? There is going to be block. Local conduction can be blocked. Can you see here? But there is going to be spontaneous recovery. Here there is no damage to endoneurium, epineurium, perineurium. 2nd classification, what happens? You can see there is some injury to the axon. Either encapsulating structures like your endoneurium, epineurium, perineurium, they are all going to be intact. Okay, Wallerian degeneration is going to be starting only at the 2nd stage. This is first important MCQ. Wallerian degeneration occurs at the 2nd degree, not at the 1st degree. 3rd one, when there is going to be injury to the axon, endoneurium is going to be disrupted. Epineurium, perineurium are going to be intact. Epineurium and perineurium are going to be intact. Remember, epineurium and perineurium, they are going to be intact. Okay, but what happens? Only your endoneurium is going to be affected. So only your endoneurium are going to be affected, epineurium, perineurium are going to be there. So this is also Wallerian degeneration. Okay, this is also Wallerian degeneration. Fourth one என்ன ஆகும் அப்படின்னு பாத்தீங்கன்னா நம்பர் 1, நம்பர் 2, நம்பர் 3, நம்பர் 4 பார்த்துட்டோம். நம்பர் 5ல என்ன ஆகுது 5th டிகிரியில ஓகே பெரினியூரியம் டேமேஜ் ஆகுது, எண்டோனியூரியம் டேமேஜ் ஆகுது, எபினியூரியம் மட்டும் இருந்ததுன்னா அது 4, 4மே டேமேஜ் ஆச்சுன்னா அது 5. பட் ரிமெம்பர் உங்களோட வெலேரியன் டீஜெனரேஷன் எங்க அக்கர் ஆகும்னா உங்க ஆக்ஸாட்மெசஸ் நியூராட்மெசஸ் சொல்லக்கூடிய 2nd and 3rdல தான் there is going to be Wallerian degeneration. In 4th degree and 5th degree, what happens is you need a surgical intervention for recovery. It will not recover on its own. 4th and 5th degree needs surgical intervention. So that is what we are like talking about. 1st degree, 2nd degree, 3rd degree, 4th degree, 5th degree in solron. Okay, so in the tableau box is more than enough for you. Axon, how it occurs, severity எப்படி இருக்கும் எல்லாமே given in this single tabular column. This tabular column is more than enough. 1st degree injury, least severe, axon is going to be intact, compression does not occur, degeneration, immediate regeneration occurs. 2nd degree now severe, damage will be there, severe and prolonged Wallerian degeneration occurs, again regeneration will be occurring. 3rdலையும் severe than damage ஆயிருக்கு, endoneurial tube is destructed, Wallerian degeneration இங்கேயும் regeneration நடக்கும். 4th degreeல severe damage, fasciculi is going to be disorganized, Wallerian degeneration occurs, regeneration will be occurring. But when you come to the 5th degree injury, most severe, it is going to be damaged, it's going to be completely transected, complete transection occurs, therefore there will be incomplete regeneration. Okay, so this is again another symbolic representation of your degeneration. In this degeneration, if you ask me, there are 2 types of degeneration. One is retrograde or proximal degeneration, other is anterograde or Wallerian degeneration. Okay, in anti-Wallerian degeneration or anterograde degeneration or distal degeneration, what happens from the site, it is going to be towards your axonic synaptic terminal, whereas retrograde now it is going to be towards your dendrite. So that is the difference between anterograde and retrograde. Okay, rough endoplasmic reticulums will be present. This rough endoplasmic reticulum will be having nissel body. This is what I want you all to understand. So what happens is when there is going to be a degeneration, okay, when there is going to be regeneration after 48 hours of injury, rough endoplasmic reticulum of neurons is called as nissel body. They undergo degeneration, they undergo dissolution, and that is going to be leading to chromatolysis. Because of this chromatolysis, okay, what happens? There is going to be proximal degeneration. This side is going to be separately degenerated. That is called as proximal degeneration. That is going to be characterized by chromatolysis. Remember, within 96 hours of injury, your proximal tube of nerve sends out sprout of allotubes. The Schwann cells emits growth factor that attracts those axonal sprouts towards injured site. If the sprout reaches the allotube, nerve regeneration will be occurring at the rate of 1 to 3 millimeter per day. So regeneration occurs at the rate of 1 to 3 millimeter per day. Okay, regeneration will be occurring at 1 to 3 millimeter per day. Okay, for this you need some growth factors, right? That growth factor is called as a neurotropins. So what are the neurotropins? Nerve growth factor. They are required for the growth of sympathetic neuron, cholinergic neurons in the basal forebrain. In the basal forebrain, you need all these things for the regeneration. Similarly, you need brain-derived growth factor, neurotropin 3, neurotropin 4, 5, etc. All these things are going to be there. Again, you have some receptors. For nerve growth factor, for example, for a nerve growth factor, you have receptor called as TRK4, DRKA. Similarly, brain-derived growth factor, you're going to have TRKB. Similarly, neurotropin 3, TRKC and TRKKB. Then neurotropin 4, 5 will be having TRKB. Okay, all this brain-derived neurotropic factor is there, right? They are very critical for regulation of neuroplasticity, resilience, for neurogenesis, etc. For all these things, you need the brain-derived neurotropic factor. Recent evidences suggest that depression is associated with the loss of brain-derived neurotropic factor. This is the basis of neurotropic hypothesis of major depression. Depression appears to be associated with fall in this brain-derived neurotropic factor in the cerebrospinal fluid as well as serum, as well as with the decrease in tyrosine kinase receptor B. So இதுக்கு வந்து mTOR pathwayன்னு சொல்லுவாங்க. I don't want to go into those things. How you can do is, than giving the antidepressants, electroconvulsive therapy is going to be appearing helpful for the depression patient. So அதுதான் basis. Okay, once you know this, next I want to talk about two important things: multiple sclerosis and your Guillain-Barré syndrome. ரெண்டுமே வந்து பாத்தீங்கன்னா it's a comparative. Multiple sclerosis is also demyelination. Guillain-Barré syndrome is also caused due to demyelination. Multiple sclerosis is caused due to demyelination of what? Oligodendrocyte. So it's going to be demyelination due to antibodies against, okay, due to antibodies against your oligodendrocytes. So what happens is, usually when there is going to be increase in temperature, there is going to be decrease in the conduction velocity. So what happens is, there is going to be appearance of worsening of symptom. This is called as Uthoff's phenomena, which is present in your multiple sclerosis. Similarly, when temperature increases, what happens? There is an increase in the potassium leakage, hyperpolarization, decrease in the conducting velocity. Okay, that is what you call it as this degeneration in multiple sclerosis. Then Marcus gun pupil. I want to talk about this Marcus gun pupil. What happens? So light in normal eyes. Just draw a tableau column like this. Normal eye, light in the affected eye. Okay, light in a normal eye, light in the affected eye. So you're going to have a pupil like this. So pupil will be constricting, isn't it? When the light is going to be there, it's going to be constricted. This part is going to be dilated. This part is going to be constricted. Similarly, off is going to be constricted. This is going to be dilated. Let's consider like this. So you're going to have a thing. You're going to have a nerve, optic nerve, which is going to be taking a, and then it is going to go to the Edinger-Westphal nucleus. From Edinger-Westphal, this too is going to be Edinger-Westphal nucleus. From Edinger-Westphal nucleus, your oculomotor is going to be transmitting. It is going to take, your oculomotor is going to take the thing to constrictor muscle. So oculomotor will be taking to constrictor muscle. Here also oculomotor is going to take to constrictor muscle. You are going to have a sympathetic system also. So what happens? Whenever there is going to be an optic nerve developing demyelination, when this optic nerve is going to develop demyelination, if you are going to throw the light on this nerve, okay, this nerve is not going to take the impulse to the Edinger-Westphal nucleus. Okay, this is not going to take the Edinger-Westphal nucleus. Okay, if light is going to be shown on the affected eye, this is not going to take response to the Edinger-Westphal nucleus. Therefore, what happens is, there is no constriction of your pupil. There is no constriction of your pupil. Remember, if this both are going to be interconnected, or both Edinger-Westphal nucleus are going to be interconnected. Therefore, when a light is going to be transmitted impulse to the Edinger-Westphal nucleus through your optic nerve, it is going to stimulate not only your same eye, it is also going to be stimulating the opposite eye. Therefore, this is going to be a normal eye. Whenever there is a light is going to be caused, it is going to stimulate your optic nerve, Edinger-Westphal nucleus. Therefore, there is going to be constriction of your pupil through your oculomotor nerve, both the same side as well as the opposite side. Therefore, when there is going to be affected eye, it is not going to be constricting the same eye as well as opposite eye. Now, listen carefully. This is going to be normal eye. This is going to be the affected eye. So, when you're going to show light in the normal eye, both your normal eye as well as your affected eye is going to constrict. Normal eye as well as your affected eye is going to constrict. When the light is thrown on the affected eye, both normal as well as affected eye is not going to constrict. So these two are the actual difference. Okay, now coming to the next one, what is internuclear ophthalmoplegia? I think you have to listen to this carefully. This is very, very important. Okay, this is very, very important. Internuclear ophthalmoplegia. So what happens is, I'll just tell you, just look at my face. I think you all visible, you all are visible. Okay, now you have this thing. So if I wanted to look to this side, if I wanted to look towards my right side, my right eye actually should look towards the lateral aspect. My right eye should look lateral aspect. My left eye should go medially. So my right eye should go laterally. My left eye should go medially. Okay, my left, okay, if I wanted to look at left side, my left eye should look laterally, my right eye should move medially. That means that my left eye oda lateral rectus muscle must be acting, my right side oda medial rectus muscle has to act. Okay, left eye oda lateral rectus muscle, right eye oda medial rectus muscle. Okay, so this should be the actual thing. Now, in order to look into that point of view, so இப்போ எனக்கு வந்து அந்த சைடு பார்க்கணும் அப்படின்னு எனக்கு தோணுச்சுன்னா, ஓகேவா, so what I have to suppose to do, what I supposed to do, okay, that is what my question is. Now I'll tell you, if I wanted to look towards that side, that is towards my left side, suppose in this picture, let's consider the same picture. Suppose I wanted to look towards the left side, okay, towards the left side, I wanted to move both these muscles simultaneously. Both these muscles has to contract simultaneously. Okay, so who is going to help in this? Who is going to help in this? Medial lateral fasciculus. So your medial lateral fasciculus has to help, because your right eye, that is going to be your right eye's medial rectus. You all know that. What is that quick mnemonic? LR6, SO4, rest 3. LR is governed by abducens nerve. SO4, okay, we are not concerned. Rest is going to be governed by 3, that is oculomotor nerve. So oculomotor nerve is going to go and transmit the impulse to the medial rectus motor neurons or oculomotor nucleus. Your lateral rectus goes and gives information to the abducens nucleus. So both are separate nuclei, guys. So you have two important nucleus. One is abducens nerve nucleus, other is going to be oculomotor nerve nucleus. So these two nucleus has to work in the coordinated manner. That means that these two nucleus has to do a coordinated function. Who is going to help in that coordination? This is going to be done by median lateral fasciculus, MLF. This medial lateral fasciculus may undergo demyelination. That condition is called as internuclear ophthalmoplegia. Very clear? So when there is a MLF demyelination, they are not going to work in a coordinated manner. They are not going to work in the coordinated manner. You know that first your lateral rectus muscle is the one which has to move. So your mind will be giving stimulus to the lateral rectus muscle. So in order, that is going to be coming from PPRF. Okay, from PPRF, you're going to have the transmission of impulse to the abducens nerve. This abducens nerve will go through the lateral rectus motor neuron to move your lateral rectus. At the same time, it will be giving impulse to the median lateral fasciculus to tell your oculomotor nucleus to move your medial rectus. But here what happens? MLF fails. Therefore, your lateral rectus will be moving, but your right eye does not move. Only your left eye will be moving. Right eye will not be moving. Therefore, there is going to be a, okay, there is no medial movement. There is going to be horizontal gaze. So this is going to lead to nystagmus. So diplopia will be there. Overaction of your abducens will lead to nystagmus. So there is going to be a nystagmus. There is going to be a diplopia. There is going to be a diplopia, nystagmus, etc. So this is what I wanted to convey through internuclear ophthalmoplegia. Next, we are going to move towards is Guillain-Barré syndrome. What is Guillain-Barré syndrome? Guillain-Barré syndrome is nothing but same. There is going to be a PNS demyelination. Instead of CNS demyelination, in Guillain-Barré syndrome, there is going to be antibodies that are going to be produced against your Schwann cells. There is going to be antibody that is going to be produced against your Schwann cells. Because of this, what happens? Your motor nerve, sensory nerve, both are going to be causing conduction impairment. Both motor and sensory conduction impairment is going to occur. Conduction impairment is going to occur. Because of this impairment, what happens? Maybe due to some infection. What are the infection? Campylobacter jejuni, influenza vaccination, etc. Their antibodies are produced against the. So first, what happens? Antibodies are produced against the viral agents, but it is going to mimic. Okay, it's going to mimic. Therefore, what happens? This produces antibody against your squamous cells. Because of the antibody produced against the squamous cells, what happens? There is going to be demyelination. Okay, so this is a post-infection immune sequelae actually. So this begins at the distal joint, like your lower leg, then slowly it ascends towards your proximal joint. So because it reacts to the squamous cell, it causes ascending motor paralysis. It starts from the distal neuron, it goes to the proximal joint. So there you're going to have a ascending motor weakness. What will be your treatment? Plasmapheresis, immunoglobulin, IV immunoglobulin is going to be given. This is going to be your GBS. I think with this, we are actually completing all the essentials of your nerve physiology. Now, what we will do is, coming Sunday, we will have a test in muscle physiology, followed by nerve physiology. Then we will go for the discussion. We will actually go for the discussion. Is it clear, guys? Okay. Thank you so much. So let's meet you in the other session. Thank you.